Hi, everyone. It's great to see you. Oops, I think I just closed my slide. Sorry. There we go. Really excited to have you here with us today. For those who don't know me, my name is Gabi Conacher. I am the co-founder of Deep Connections, which is a group of more than 40 different patient advocacy groups working together to bring critical information to families who have kids that are really severely impacted by these developmental and epileptic encephalopathies. And I am so excited today for this webinar that we are doing in partnership with our friends at KCNT1 Foundation. Sarah Drizzlane and Shannon Weir brought this topic to us. And personally, as the mom of a 9-year-old who's really complex, and we have a lot of dental challenges. So I think I have a lot of questions. We'll see. I think we have a lot that were submitted in advance. So we're going to go ahead and jump in. I'll start by introducing our guests. Shannon Weir was born and raised in Mesa, Arizona, and is the 6th out of 8 siblings. Growing up, she was the recipient of compassionate free dental care from a mobile clinic for children in poverty. And she knew from a very young age that she wanted to be a dental hygienist who cared for kids like when she was young. So after graduating from dental hygiene school, she practiced and volunteered regularly for providing free services to unhoused population in Utah. She spent a month on a dental service mission in Kiribati, one of the most underdeveloped countries in the world. And in 2017, Shannon felt the need to widen her scope of practice and re-entered university with the goal of becoming a doctor of dental surgery. After graduation, she plans to attend a hospital dental residency where she will receive specialized training in complex care and sedation dentistry. She intends to focus her dental career on caring for patients with special healthcare needs, who I should also mention, she has a child with special healthcare needs. She is a KCNT1 mom. So she comes at this with a very unique perspective that mirrors a lot of us who are on the call today. She currently resides in Salt Lake City and lives with her husband and 3 children, and they enjoy being together as a family and any excuse to be outside, no matter the weather. And we also have with us Dr. Hans Reinemer, who is a board certified pediatric dentist. He lives in Holiday, Utah with his wife and 3 children. So he graduated with a Bachelor's of Science from the University of Utah and received his doctorate in dental medicine in 1991 and was accepted to the residency program in pediatric dentistry at the Baylor College of Dentistry in Dallas, Texas. So his experiences during the training program there provided him with the confidence and knowledge to treat children of all ages, as well as children with complicated medical histories and special needs. He completed his residency program in 1993 and received a certificate of advanced training in pediatric dentistry, as well as a Master of Science degree in oral biology. So you're in very good hands here. He's a member of the American Dental Association, a number of other different groups, the American Academy of Pediatric Dentistry, and he currently serves as the medical director for the Pediatric Dental Residency Program and is the division chief of dentistry at Primary Children's Hospital in Salt Lake City, among other things. And he enjoys cycling, camping, hiking, fishing, and any outdoor activity, and cheering his family on in anything that they're doing, which I love. It's really great to have you both with us today. I'm going to stop sharing. I'm going to go ahead and let you guys take over. There's a lot to get through today, but please, as we're going throughout, feel free to put your questions into the Q&A. Share your experiences in the chat if what Shannon or Dr. Reinemer are talking about resonates with you. We'd love to hear from you. And as we're going throughout, all participants are muted and off camera, but we definitely want to hear from you in the chat. So take it away. Thanks y'all for being with us today.
Thank you.
Thank you.
Thank you for that introduction. I just wanted to share, before I get started on the PowerPoint, I just wanted to share a little bit more about my son, who has KCNT1 epilepsy, which is a degenerative epileptic encephalopathy. He's 3. I had him just after I was accepted to dental school. I had him, and it was a big surprise, big change for our family. I never envisioned myself as a special needs parent, but it has really been something that has propelled my career in dentistry into serving patients with special needs, which is I didn't know would be such a passion of mine, and now is. So I'm thankful for that. So yeah, anything else you wanted to share before we get started, Dr. Reinemer?
No, please go ahead.
Okay. Let me go ahead and share my screen here. All right, give me 1 second so I can get the presenter view up here. Okay. All right, so welcome. Thank you, everyone. We're so excited to be here and sharing this information with you. I hope you get a ton of information from it. I'm excited to be sharing some of what I've learned both as a dental professional and as a parent of a medically complex child. I just wanted to go over a few disclaimers. Anything we say shouldn't replace information you receive from your doctor or your dentist. This presentation is purely educational and not intended to provide medical or dental advice specific to any patient's care. Also, I may refer to people who don't eat by mouth generally as children, or I may refer to them as patients. My intention is to speak to the lived experience of all people who don't eat by mouth, but it's difficult because the spectrum of various conditions that cause someone to need enteral feeding is vast. So just please forgive me for any generalizations that I make. And if you need clarification that's specific to you, you can type that into the chat, and please send all your questions in the chat and we'll have time for them in the end. So a little bit about what we're going to, just kind of a brief summary about what we're going to cover today. We're going to cover oral conditions associated with enteral feeding and epilepsy, also dental effects of various commonly prescribed medications, how, when, and where to and why to seek professional dental care, and what to expect from your dental provider. We're going to go over some practical tips on how you can care for your child's oral health at home. But before we dive into all of that, we need to start with just a few of the basics. So what is the process of tooth decay and how does a cavity form? I hear a lot of people say that bacteria eat holes in your teeth. And that's not exactly right. It's close. When bacteria that cause cavities are exposed to sugar, they break it down and their byproduct is acid. So then that acid eventually sitting next to a tooth will weaken it and create holes in the enamel. So that's like the basics of how a cavity starts. So it's not really the bacteria eating holes in the teeth. It's more like bacteria eating what we eat and then pooping acid onto our teeth, which is gross. Also, so we're not defenseless against the acid attack. We have saliva, and saliva is a natural buffer. It helps neutralize acid. It also contains antibacterial properties. So then if saliva is so perfect at buffering, why do cavities still form? There are a couple main reasons why saliva alone isn't enough to fight cavities. A common reason is frequent eating. So I'm going to use terms like eating and food and sugar, but it's important to understand what I mean. Eating might not apply to your child if they're exclusively tube fed, but some people who are primarily tube fed still eat orally sometimes. Also keep in mind that sweet liquids or medications, if taken orally, count as an eating event. And sugar doesn't necessarily mean candy or something you might think of as sugary. It means anything that bacteria can digest and break down, which is basically everything. So frequent eating is a very destructive to teeth. This graph that I've put up, it shows what happens to the pH in the mouth after exposure to sugar. pH is a measure of acidity. So low pH means lots of acid. The gold line represents the pH of the mouth and the black line is the danger zone. So anytime the gold line dips below the black line, the tooth is being damaged. And within 3 minutes of eating food, bacteria is already hard at work in digesting the food and producing acid. The pH drops right away. Then it gradually, slowly goes back up when the saliva is buffering. So you can imagine what would happen if during that slow process of buffering back up, if you had another eating event and what would happen. So this is another graph that represents in red, if somebody were to have a frequent eating, it would result in a lot more time during the day in the danger zone. So that's kind of the basics of how that works. Another reason saliva isn't always enough to prevent tooth decay is that bacteria don't act alone. They gather in these huge numbers and create this vast community, and they all work together. And one thing they're extremely good at is creating a sticky matrix around their group that insulates them from the buffering capacity of the saliva. So if you've ever noticed like a pale film on your teeth, that's that sticky matrix. It's filled with bacteria. We call it biofilm or plaque. Here it is represented in yellow. And you can see how the plaque is protecting a colony from the saliva. while they dump acid just right onto the enamel surface. And that's why we see cavities in areas where plaque accumulation is the greatest. So the big takeaway is that you can reduce your risk of tooth decay by reducing your frequency of sugar in the mouth and regularly removing the plaque with a toothbrush and floss. But tooth decay is not the only oral disease that we're concerned about. The other important thing to talk about is periodontal disease. The word periodontal literally just means around the tooth. So periodontal disease or periodontitis is a disease of the bone, ligaments, and gums around the tooth. So you've probably heard of gingivitis, and what is it? Gingivitis is the initial stage of periodontal disease where the gums are inflamed, but tissue destruction hasn't taken place. So then there's also periodontal disease, which is when inflammation has caused some loss of the structures. So why does this happen? Is it the acid? No, it's not acid this time. Periodontal disease is an issue of irritation and inflammation. So what is so irritating the gums? Well, as that saliva mixes with the plaque that's stuck on the side of the tooth, the heavier mineral content of the saliva precipitates out of the saliva and forms like hard deposits, like lime scale or hard water deposits. But that calculus that's stuck to the tooth is not directly damaging to the tooth because acid doesn't actually get through the buildup. In some ways, it's actually protective, but even though calculus doesn't directly cause disease, it's still a problem indirectly because the rough buildup provides a surface for bacteria to just hang out. And where the calculus sits right next to the gums, this is where it becomes a big problem. And this is an important concept to understand because people who don't eat by mouth, they typically have an abundance of calculus, which means they're particularly at risk for developing periodontal disease, and their risk for cavities is actually quite low. So this is a child with special needs who's tube fed, and you can see the massive buildup of tartar, that yellow calculus over the tooth that's just completely covering it. And then after you're done looking at that, look at the gum tissue right next to it. And you can see that it's bright, it's like a red, like a dark red color outlined. That is inflammation. That's periodontal inflammation. And we see that a lot. So the bacteria that cause periodontal destruction aren't the easygoing, friendly community builders. They're actually really bad guys. They're even like insidious. They sabotage the body's own defenses and turn them into a weapon of destruction. They're irritating to the gums, and the body sends all kinds of defensive chemicals to try and rid the body of the infection, and that leads to chronic inflammation, which is what effectively destroys the bone, ligament, and gums around the tooth. And this process is irreversible. So if enough tissue is damaged, the tooth becomes mobile and falls out or needs to be extracted. Another reason to be concerned about these bad bugs is that it has to do with aspiration. Patients who don't eat by mouth and have neurological disorders typically have some type of swallowing deficit or dysphagia and are there at higher risk of aspiration pneumonia. One of the biggest bad guys in periodontal disease that we know of is a bacteria called Porphyromonas gingivalis, and it's indicated in some severe cases of aspiration pneumonia. It's a bad bug. It's hard to get rid of. But the point is, we don't want our kids harboring all these bad periodontal pathogens in their mouths. So let's get into more specifics about how all this information relates to a person who doesn't receive nutrition by mouth. Enteral feeding is the term we use for anyone who receives nutrition by G-tube, GJ tube, NG tube, but we could simply use the term tube fed. Some who are tube fed may eat by mouth at some times. They may take some medications by mouth, and these differences would have different implications regarding their health, their oral health, and their risk. So all of the different reasons why someone is tube fed could be various. So we're going to kind of focus on our discussion on people who have degenerative epileptic encephalopathy and the dental effects on this group specifically. So dental conditions related to tube feeding, like we talked about, that increased buildup of calculus and increased rates of periodontal disease and decreased rates of decay. And then dental conditions that are sort of related are grinding during seizures, dental trauma from seizures or falls, biting their tongue, having jaw pain and TMJ issues, increased secretions or drooling, or possibly decreased secretions because of the interventions for drooling, mouth breathing, possibly dental developmental abnormalities if the epilepsy is part of a syndrome. And then we're also going to talk about some frequently reported dental effects that may or may not have anything to do with enteral feeding or epilepsy, but that seem to have some sort of relationship. And that's delayed eruption and eruption cysts, and also acid reflux or vomiting. So we'll kind of go into more detail about those things. I'm going to talk about bruxism. Bruxism is another word for clenching and grinding. It's thought to be a neuromotor dysregulation disorder. People with epilepsy usually grind their teeth during seizures, which is a little different than someone who, say, grinds their teeth at night. But sorry, the lights turned off on me. Sorry. So yeah, people that grind their teeth at night, but the effects of grinding can be the same or similar, except that seizure grinding tends to lead to more acute trauma, like breaking teeth or actually grinding so hard that the tooth wiggles out. While most other types of bruxism lead to chronic changes like tooth wear and attrition. These 4 pictures are of trauma in a child from grinding during seizures. So another one is eruption cysts. An eruption cyst or hematoma is associated with erupting primary or permanent tooth that's in the soft tissue phase. So it's erupted through the bone when there's only soft tissue covering it. Usually that period is short, but if you have a delayed eruption, it could be a longer period. So the lesion starts out as usually translucent, smooth. It looks like a swelling over the erupting tooth. And if bleeding occurs into that cystic space, it may appear blue or blue-black, and then it's called an eruption hematoma. And this is one of the most frequent dental questions I see in special needs parenting groups for children who are tube fed. My observations are purely anecdotal because published research about eruption cysts specifically affecting this group is limited or non-existent. But if I had to bet, I would say that many of you here on this webinar have seen something like this in your child. The exact cause of an eruption cyst isn't fully understood, but evidence suggests that the condition develops as a result of trauma to the soft tissues during function. So many children who are tube fed also have delayed tooth eruption, and the causes for that can't really be generally stated. And the mechanisms of eruption are really too complex to go into for this discussion. But it's reasonable to speculate that children who have been having seizures since infancy and intensely grinding their jaws together without their erupted teeth could be experiencing a prolonged trauma to the soft tissues. So that could be causing the eruption cysts. In neurotypical children, eruption cysts are almost always self-limiting, meaning they go away on their own and the tooth erupts within days or maybe weeks. So treatment is rarely necessary for them. But however, if the cyst is not resolving on its own, then surgical uncovering of the crown could be justified. The cysts are thought to be painless, but in nonverbal children who have prolonged presence of eruption cysts, we can't really know if it's causing oral pain. And because it's an uncommon procedure, if this is something you're concerned about, you would need to find a dental provider who's familiar with it. The decision to surgically uncover the cyst, which is called marsupialization, it needs to be made on an individual basis. So you'll have to talk to a dentist about that. So this picture is actually my son, Loyal. He's 3. None of his baby molars erupted, and they all developed eruption cysts. When I say erupted, the crown didn't come out into the mouth. But they erupted, but they have these cysts over them. So you can see in the photo how large those cysts are. And so at this point, we decided that he'd had them for about a year and we were monitoring them. And then he was going through a time when it seemed like he was having some unexplained pain, and our efforts to rule out anything, we decided, well, maybe he is having oral pain. So we made the decision to do the marsupialization. So this is just a little video of the procedure, just like the start of the procedure. This was actually, it was fairly straightforward. He was able to have it without sedation in the dental clinic at Primary Children's Hospital. Actually, all of Loyal's dental care has been provided by the pediatric residents there, where Dr. Reinemer is the director. So he's doing an awesome job. Loyal had local anesthesia for this, so he was numb, but he didn't need sedation. And recovery was just with ibuprofen and antibiotic rinses twice a day. And he really didn't seem to mind at all. And I think it did relieve some discomfort. So let's talk about medications, because this is a big topic. due to the medical complexity of people who are tube fed and who have degenerative epilepsy, there are myriad of medications that will be prescribed over their lifetime. And there's no way that I could go into detail for all the different combinations of medications. So we'll just touch on some of the most common drugs and that have the most prominent oral effects that we know about. There are a lot of anti-epileptic drugs or AEDs, and many of them do have oral effects. Your dentist can provide you with information on the drugs that might be affecting your child specifically, but the one thing that we're going to go over that you should know is that many AEDs have been known to cause gingival overgrowth. Gingival overgrowth is most commonly caused by phenytoin or dilantin, two names for the same drug, but it can be caused by other AEDs too. It's just phenytoin is like the most recognized. It definitely, you know, in most cases does cause that. Also, immunosuppressant drugs or calcium channel blockers also cause this. Gingival overgrowth usually looks like this kind of pebbly surface that looks sort of lumpy, or like you can see the outline of the teeth covered by thick gums. And if someone's taking more than one drug that causes gingival overgrowth, then the effects are actually synergistic. So it can kind of compound. And they can be treated with surgical removal, but the chances are that it will grow back, especially if they're taking the same medications. But what we also know is that plaque is an induction effect to it. So the cleaner, you know, you can keep the mouth, the less likelihood that this process will start. So home care is really, really important. Next, we want to talk about kind of two things together, the ketogenic diet. That's another common treatment for epilepsy that has some known oral effects like acid reflux, constipation, vitamin deficiency, ulcers. Pain meds can cause dry mouth, vomiting, gastroesophageal reflux disease, impaired swallowing, and constipation. So what effect would reflux and vomiting have in the mouth? And we already talked about acids, so we know that acid is not good for the mouth. This kind of acid that comes up from the belly, that's called intrinsic acid. So intrinsic acid can be very destructive. It causes dental erosion, which is the breakdown of enamel with no bacteria to blame. Dry mouth is almost always present in this type of destruction. Erosion can be made worse by grinding as well. It can cause really, really sensitive teeth, especially to cold. And these erosive lesions produced by gastric acid usually start on the upper teeth, and after a while they affect the lower teeth. And you would see like cupping of what's usually pointy. It might start looking flat or cupped. And over time, the enamel would get really thin and maybe chip off. And in later stages, you would see that yellow flattened surface. And this is something you'd need to see your dentist about for certain. Let's talk about anti-sialagogues. That's quite a word. That is medications that you would give to reduce salivary secretions. So they're commonly prescribed for patients that have swallowing dysphagia. The most commonly ones are atropine, hyoscine, and glycopyrrolate. Another common procedure that I've seen a lot is Botox injections, and some people actually choose to surgically remove saliva glands. So let's talk more about the implications of those treatments. So sialorrhea is another word for drooling. It refers to unintentional saliva leaking outside the mouth. Drooling can either be true hypersalivation, where there's actually more saliva being produced by the glands, or false, which means that there is a normal amount of saliva, but swallowing is inefficient. So true salivary hypersecretion is usually caused by food, teething, oral lesions, medications, or somebody who has an NG tube. It stimulates salivation. False or apparent hypersalivation is almost always caused by neuromuscular dysfunction, so lack of swallowing. Drooling can cause skin irritation on the outside of the mouth and a yeast infection in the corners of the mouth, and that can also lead to loss of fluids and electrolytes. Patients who drool have the swallowing dysfunction are at increased risk of aspiration pneumonia. So xerostomia is a big word for dry mouth. and that's the lack of saliva. And we have to talk about dry mouth for a few reasons, because all of our efforts to stop the person from aspirating on their own secretions do have an effect on the saliva rate and composition. So the saliva rate may significantly be reduced from surgical removal of the saliva glands or the Botox injections, but the drugs, they usually change the composition of the saliva and they make it less effective. It gets thick and ropey. Dry mouth can also be caused by open mouth breathing, which is also a common thing for our kids. So when people breathe with their mouths open, the air gets mixed with the saliva and the water evaporates out of it. That leaves that saliva thick and ropey again, and it's ineffective at hydrating the oral environment. So that's this is an example of my son, this picture. And he's a mouth breather and a drooler. And in the morning, it's not uncommon for us to find that his lips are dry and the anterior tip of his tongue has gotten cracked and bleeding sometimes from a night of mouth breathing. And you can see that the tongue looks all glassy and smooth. Dry gums also look glassy and they bleed easy when they're dried like that. And in the daytime, we focus on moving the saliva around and keeping his lips hydrated. Next, we're going to talk about oral steroids. So another commonly prescribed treatment that goes with respiratory therapy for kids who are hypotonic, like a CPT vest therapy, cough assist, that sort of thing. And I'm going to go back to that one. Nebulizers treatments as well. The main oral effect of these drugs is candidiasis or thrush, you might have heard it called. The presence of candida, which is the yeast or a fungus on the human body, is typical and it's well tolerated. So there's our little yeast and we have them all over us. They're normally viewed as being non-pathogenic because they don't usually cause issues. But the situation can change when the normal environment is compromised, such as when there's immune system compromise, there's oral lesions or injuries in the mouth, or if the person has dry mouth or nutritional deficiencies, or even the use of broad spectrum antibiotics. If your child's on antibiotics, you could get a yeast infection, as well as chronic use of corticosteroids like the oral inhalers. Antifungal ointments can be prescribed from your dentist or your doctor. Typically, they clear the infections rapidly, but some things to keep in mind is that antifungals often contain a lot of sucrose, so they're sugary, which contributes to the development of cavities, especially if you have dry mouth. A person who uses like CPAP or cough assist, it's important that the tubing are sanitized thoroughly after a fungal infection. Candida is the most common oral infection, but they're not the only fungus out there, and other fungal species are a lot more concerning, and you don't want a localized infection to become a systemic infection, which can be harder to treat. This is what thrush or candidiasis looks like in the mouth, like a spongy, cottage cheesy appearance that you can scrape off, and sometimes it's red underneath. And Dr. Reinemer, take it away.
Okay, thank you very much, Shannon. Good information. I really do appreciate Shannon's invitation to participate. You know, I've been in this 30 years so far as a pediatric dentist, and some of my very best moments and my privilege and my honor is to treat kids with special healthcare needs. And I really do appreciate sharing some information with you. So, you know, big question here: how, when, where, and why should I call the dentist? And what can I expect from a dental provider? You know, these are all really important questions that you're all probably wondering if you haven't been to the dentist so far. And a common question I look slide that represents a fair number of unusual conditions. If you see soft tissue or discolorations or things affecting the contours of the gum tissue, for example, these could potentially indicate some level of infection, and that could range from simple gingivitis to something more significant, such as a tooth related infection. So anything that looks out of the ordinary, whether it's the gum tissue or the tooth itself, or anything that looks like it's creating a hole or a discoloration on the tooth, these are all things that you want to follow up on, because it very well could be nothing, but it could be something, and you want to get ahead of everything, especially if you're dealing with a kiddo with special healthcare needs, because the link between the oral and dental health and the systemic health is quite significant. So That's why establishing a relationship with a dentist is so vitally important. So when I say that, I talk mostly about the establishment of what we call a dental home. And hopefully everyone listening today has established a dental home. Our national association, which is the American Academy of Pediatric Dentistry, recommends that you establish a dental home for any child by 12 months of age, 1 year, or within 6 months of eruption of the first tooth. So many of the kids that we're talking about on this webinar might have some delayed dental development, but I would say any child that has a special healthcare need should really focus on that 12 months of age. And the first question I get when I tell somebody that is, well, what in the world are you going to do for my baby that's only 12 months? Well, the whole point is that we hope we're not doing anything other than just providing education, what we call anticipatory guidance. What can you as a parent expect in the coming months or years, whether it's growth and development, whether it's education on hygiene, what the relationship between oral health and the systemic disease. There's a lot of education that we can do in an effort to prevent oral and dental disease, which commonly, is an issue with kids with special health care needs. And so 12 months of age is really when you want to establish. Now, finding a dental home, someone that's willing to see your kiddo at 12 can sometimes be a challenge. And so for very, very young kids, I would encourage everyone to really seek out a pediatric dentist. We, through our additional 2 years of training, become very, very comfortable with infants. I've seen kids 2 days of age. So we're very comfortable with dealing with that age group, how to manage that age group. And again, we're the pediatricians of dentistry. And so we can really help you kind of develop an idea of where we are now, where we headed, what's important. As the child grows and developments, there may come a time where the child ages out of us. They may remain a kid in many ways, but as they develop their permanent dentition, as they lose their baby teeth and develop more permanent teeth, then it becomes a challenge for us because you might be dealing with some dental issues that are beyond what we provide as pediatric and a scope of care issues. And then at that point, we talk about transition of care. And then we're looking for someone who, a dentist, for example, Shannon mentioned that she's looking at going into a hospital residency post-graduation. So there are a lot of dentists who have spent an extra year after dental school training in a hospital and dealing with the same population of kids who are now young adults and adults. And so the community gets pretty small at this point. And so, we would help you make that transition and identify best providers who are comfortable with this population. And important in a lot of cases is providers who have access to the hospital, because a lot of times we have to do things under sedation or anesthesia. And so having someone that's comfortable making those decisions and working in those facilities is vitally important. Specialists can be harder to find sometimes in rural counties, for example. So for those of you who are listening who might not live in an urban center, sometimes that may be a challenge and it might require some travel. We see at Primary Children's here, we see patients coming from all the surrounding states, Utah, Wyoming, Nevada, Idaho. And so a lot of people do have to travel, but I think it's worth the trip, identifying people who are comfortable with children and then children with special health care needs. And so if you establish the dental home, what that gives you is a relationship. And the relationship is so important when you have a question. This looks different. I see something that seems unusual compared to maybe another child in the family. My child seems to be in pain. Things aren't growing and developing correctly. If you have established that relationship at infancy at 12 months of age, and you develop that relationship with regular checkups, you have an easy person to call. Whereas if you don't have that dental home, then you're sort of struggling with who to call and who's going to be appropriate. So establish that dental home early so you have a resource. Anytime you see any level of trauma or infection, anytime a child falls, anytime you see something that looks unusual, those are times you make that phone call to your dental provider, because you want to make sure that it's, first of all, hopefully it's nothing, but if it is something, how do you get ahead of it and how do you manage it appropriately? Because again, we don't want any oral or dental condition to affect them systemically. And then certainly sedation is a common question. Within the special healthcare needs population, there are times we have to do a lot of things under sedation because of behavior management issues, or just simply because it's safer. When we're talking about kids who are tube fed, there's a reason for that. They have dysphagia, they can't manage their own airway very well. And so to do anything beyond basic exams and limited things, very commonly we're working with pediatric anesthesiologists because that's the safest environment in which to deliver care. And so as you're making phone calls and establishing relationships, find providers who have access to the hospital, because when the time comes that you do want to do something under anesthesia, these are people that have privileges in hospital settings, and it's very easily done. Let's see, what else do I have on here? Yeah, a lot of kids can do fine for limited exams and maybe some basic cleaning and things like that. But there are times when you have to take that step to the hospital. So that's why that training for that provider that you've established that relationship becomes so vitally important. In the interim, you know, we can manage caries in a variety of different ways. We've got, you know, fluoride materials that we use. We can do some minimal cleaning. We can sometimes even do some restorative procedures. And so not everything has to be done under general anesthesia. That's a case-by-case determination, often in association with developmental milestones. And so don't be afraid to, you know, get in with a provider who has hospital privileges, and don't think that you have to go to sleep every single time. That's a decision that's made for each case. This is a slide that demonstrates what silver diamine fluoride is. This is a product that's been used for many years in many areas of the world. It's become more popular in our country, especially during COVID. We found this to be very, very effective. But basically, it's a fluoride product that contains silver as well. So it's a two-component system. The silver is actually antibacterial. So if you look on the lower left there, so you see a kind of a brownish cavity on that tooth. And so if you scrub this product into this tooth, the silver kills the bugs, and then the fluoride component remineralizes the tooth. And so for kids who do require significant intervention in terms of sedation or anesthesia, and you're trying to postpone or delay, maybe, for example, they have another procedure coming up in 3 months and you want to kind of hold things off until you can coordinate care between providers. This is just one of the many examples. This is a product that can be used to sort of arrest the decay and buy you time. So what can you expect from a dentist? So let's assume that you're trying to establish a relationship with a dentist and you want to find a best fit for you as a family and for your child that may have special health care needs. I think it's really important when you make a call that hopefully you will have done your research. You know, find a pediatric dentist that's comfortable with special health care needs, someone that did some training in the hospital, and be very upfront when you call. I think it's very beneficial for us as a provider if I see someone that's scheduled for a new patient exam and I know, for example, that the parent has alerted me to some medical complexity. It gives me an opportunity to kind of review. It gives me an opportunity to maybe schedule more time. So we can make sure that we have an environment that's comfortable for you and your child, and we have the time to really work through all the unique conditions that are going to be very different from a kid that doesn't have any sort of medical problems. And so when you make that phone call, I would ask, are you comfortable with this particular situation? You know, are there certain times of the day that work better? It's sometimes pre-visits are really good, making sure that your child is comfortable in certain environments, make sure that their office is accessible to wheelchairs if that's what you need. You want to come to the office well prepared with all of your physician's contact information, because you know, one thing, when you graduate from a hospital-based residency program, we're not, and I'll be just upfront, we're not going to remember every detail about every disease process, but we're going to be comfortable knowing how to have a discussion with a parent who truly is the expert. We're going to know what questions to ask. We're going to know what providers to call. We're going to be your quarterback in these situations. And so as much information as you can give to us at that first visit to help better the team with all the information. It just gives us resources that we can make phone calls and just make sure that, okay, this is what needs to be done. How can we best deliver care for your child? You're going to know the best. I mean, I got very comfortable asking parents, tell me what you know about your child, because honestly, they've done more research than almost anybody. And so parents can be very helpful. So come prepared, willing to discuss and educate the provider, because we do know a lot, but you know more. And I think collectively, it just benefits the child when we have that open communication. And then when you're at the visit, ask how you can help. I think that depending on the comfort level of the child, is this a child that can sit in the chair? Do they need to remain in the wheelchair? You know, what are some likely things that we're going to encounter? For example, you know, we see a lot of kids who have seizure disorders, and if, you know, dental students are trained that if you see a seizure, this is how you manage it. But if we find out from the parent that, well, my child has seizures 12 times a day, and the seizure that we're witnessing right now is a pretty normal event, you know, that's important to us, because otherwise we're going to treat it as a medical emergency when it may not be. This is a routine event. So this is the kind of a communication that we appreciate as providers, just find someone that's willing to listen, find someone that's willing to let you help. And then I think collectively, it just ultimately benefits the child.
Thank you.
So, yeah.
I'm going to go into some oral care at home strategies. And I think that a lot of the questions that we had come in were about this. So I have a video that I'm going to show at the end that will kind of demonstrate some of these things, but just remembering the basics. We're trying to reduce the amount of acid that's in the mouth, remove debris, and strengthen the enamel. I'm going to talk about some products super quick. The toothpaste for these kids that have dysphagia swelling, it's not needed. So the sodium lauryl sulfate is an ingredient in toothpaste that causes it to form the soapy bubbles, and that puts a person at risk for aspiration. It's just not necessary. So, but using some type of solution or rinse soaked on a sponge, that's better. Here are some options that I recommend for certain situations. So chlorhexidine is prescription rinse. You might get it after a surgery or to help reduce gingival inflammation, periodontal disease. The goal of that rinse would be to reduce the overall bacterial load in the mouth, so bring the bacteria numbers down. You would not use this every day. It does cause staining if you use for long periods of time. And there's better things that you could use every day. And that's, again, that's a prescription you would get from a dentist. So you can't just run out and buy that. But these other things you can, and you can use them every day if you want. Closest is a chlorine dioxide rinse. It's very gentle on oral tissues. There's no alcohol in it. It tastes very mild. You can actually get it completely flavorless. It's the best for killing bad odor. So if you have a child and you're concerned about their breath smelling bad because of dry mouth or other things, the chlorine dioxide is extremely effective at that. Xylitol is another one. It's a non-sugar sweetener. You can buy it in bulk in like the granular form. It just looks like sugar, or you can buy it in the oral rinses like Spry or Clear. They have their own oral rinses. It's sometimes advertised as like a cavity prevention or ear infections, preventing ear infections because of its bacteria killing properties. So the research on the effectiveness of that actually happening is questionable, non-conclusive, but what we do know is that it doesn't harm. There's no harm unless you have, some people have a sensitivity to it. So if they swallow a lot of it, it can cause some digestive issues, but we're not talking about swallowing it for the most part. It's fairly innocuous. What it does is it's a sugar alcohol that bacteria see as sweet. They try to eat it, but they can't break it down. And so it ends up building up inside of them until they die. So it's a pretty simple thing to use. I like to use it because it's inexpensive, you just dissolve it in water. It tastes really good, tastes like candy. My son doesn't get to have sweets very often, I mean, ever. So we use it every day. I also use it every day for a nasal conditioner, like a nasal spray when I do a nasal clearance. So this is just my experience. It's purely anecdotal. There's no research behind this, but they do advertise that it reduces ear infections. My children, I've used it for all three of my children, and none of them have ever had an ear infection. And I had ear infections chronically as a child. So It doesn't hurt. It may possibly help, and it's inexpensive. So those are some good reasons to use xylitol. I'm going to kind of just move through this really quick because there's a video that I want to play if we have enough time. It's like a 5-minute video because I think that's a little bit more effective at teaching. But there's options for suction toothbrushes if you have a suction machine at home, which most people do if they have issues with swallowing. And so I'm going to move on to that video really quick. And please excuse my ums in this YouTube video. There's a link here that you can actually this is a public video on YouTube, so you can look it up. Let me just see if I can make it play a little faster. No, I can't. All right. Today I'm going to demonstrate oral care for someone who is tube fed, someone who does not eat by mouth. And so a GJ tube or a G tube. I'm going to use a variety of different suction tips. So the first one is this spongy brush. It's just got a sponge on the end and it has the suction, the controllable valve right here. So you put your thumb on there, it's suctioning, you take your thumb off and it's not. So I'll dip this in a little cap of solution of chlorhexidine. This is an antibiotic rinse you can get from your dentist. So I just put a little bit of that rinse in the cap of there and then just soak it up. When I turn on the unit, I can insert the sponge and just start in circular motions, and on and off I'm suctioning. So I'm kind of like on and off with the valve. Circular movements to get all the teeth. I'm gonna kind of do this quickly so I can get to the other sponges that I want to show you, other toothbrushes and oral aids. Okay, so there's that, and then I'm going to show you different kinds. So another tip that I have is a brush tip. So this has a sponge on one side and a brush on the other side, and this sponge is actually it comes pre-coated with an antiseptic. So I just insert that, and it's pretty self-explanatory. The saliva will kind of activate that antiseptic, and then we have a brush on this side. So I'll show you that. So when you brush, you want to use little small circles. Angle the toothbrush towards the gums, and just use little small circles. And to get inside the cheek, to get the back teeth, just kind of like use the toothbrush to kind of push the cheek out, and you can kind of retract with your finger a little bit, and just get all the way back there with that brush. Suctioning on and off, letting that brush get a little bit, the antiseptic start to get into the solution of the saliva, kind of brush that all over, and then just use those little small circles on the gums. And you can go on the inside too. See, he has an open bite, so it's easy because I don't have to use a bite block or anything. I just kind of like push in with the brush and get his tongue out of the way, and then rotate it so I'm brushing here. You can kind of see better on the lower. So I'll push in with the brush, get his tongue out of the way, and just use those little circles. Good. The next one I'm going to show you, the next one, it doesn't have, this is the little sponge lollies. They don't have a suction tip. So with this one, you can use it dry if you're just needing to kind of get some plaque off. You can use it dry and just kind of rub that plaque off. I use this a lot when he has like a buildup of like film when he's sick and he has mucus on his palate. These are good because his palate gets coated in mucus, and it will actually make like really gunk this up, and I like to use this for a full day. So these are single use, and you throw them away when you're done with it. So for this, I'm going to put on my dental tip. So this tip of the suction just fits right in. There's no control valve for it, so it's always suctioning. So I'll use this in one hand and the disposable in the other. And you can soak that in your mouth rinse antiseptic. And I'll just kind of use this to kind of retract his mouth and get this in there. And I like to get this on the palate and spin it. So rotate, I don't know if you can see that, how it's rotating. And I'll just sweep, rotate forward, and it'll get that gunk. And then I'll just wipe it on a tissue or something, and then sweep forward and get that gunk out. And you can get that, you can see I'm actually getting stuff on his tongue. There's a little bit of that gunky, stringy mess. So I'm gonna keep going on that, sweep forward and roll out. If you're gonna get the tongue, See, and I got some right there. So that's that gunky stuff we're trying to get out. And I'll just wipe that on the tissue or a chucks or a wipe or whatever. And then I'll show you for the tongue, it's a little bit harder because you're gonna swipe the other way. So you're gonna get it in there and then roll forward on the tongue. So get it all the way back there and roll forward on the tongue. Okay, I'm gonna stop it there. Because you get the point. So yeah, that was just a little bit of demonstration. You can go to YouTube and get the whole video if you want. The end is just a little bit of I talk about using a bite block, but for the sake of time, I'll just end it there, and then Gabby, we can take questions hopefully.
Yeah, that was amazing. I have to say, as somebody who's got a kid with lots of dental issues, I learned a lot. And I'm so excited for this to be a resource for the community. And we definitely have questions coming in. I have some that I've written down along the way too, but let's jump into the ones that are in the Q&A for now. So we have somebody who wrote that the front permanent teeth in their child have grown leaning towards the back of their mouth. They're exclusively tube fed, and the dentist recommends no intervention, but they worry that they might be contributing to them choking on their tongue or increased secretions. Have you ever seen anything like that? And would you recommend intervention? And obviously we know you're not giving specific advice to specific people, but like in general, is that a kind of thing that you would be concerned about in a child?
Abby, did you get the other panelists? Did they come on? Sorry, real quick. Did you get?
Oh yeah. Do you want to invite?
Yeah, Dr.
Yeah.
Becker and Proctor.
Okay. Proctor.
While you're doing that, maybe Dr. Reinemer wants to touch on your question.
The question was teeth that are leaning back in the mouth causing potentially what?
That there might be some choking or the tongue kind of sliding to the back of the mouth, I think was one of the issues.
I don't think that we call them retrocline teeth are going to push the tongue back far enough to create any sort of choking issues. And so it's mostly just what we call an occlusal discrepancy or problem. But in terms of like choking, I don't think that there's going to be enough of a tooth malposition to cause any sort of tongue repositioning and choking there. Personally, I've never seen that.
Mm-hmm. Mm-hmm. And I know that in other people, and I mean, my son, I've heard about too, but like the that very hypotonic type tongue that kind of starts to slide to the back and starts, covering the airway. Is that something that you've, with the teeth growing like that, or is there anything else that you have done or seen for people who are in that kind of situation where that tongue just really, they start to choke on it, block their airway?
Yeah, and that would be something that you would probably want to consult with an ENT specialist on. Teeth assume the position in the mouth through a balance of the tongue and lip and cheek pressures. That's how we create this alignment of the arch. And so whenever you have muscular problems, hypotonic tongues, for example, that's what then leads to malalignment of the teeth and posturing and all that. So it's very interrelated. But if any of these things relate directly to an airway issue, that's going to be beyond scope of care with the dentist. And that's when you would definitely involve your medical provider, such as an ENT.
Yeah, that's a good distinction. While I'm grabbing up the next question, Shannon, do you want to share who we've invited on screen here? I didn't see Dr. Becker, I think was the other
Okay.
name, but
that's fine. Yeah, so we have Dr. Craig Proctor. He is a special care dentist, a hospital dentist at the University of Utah Hospital, and he runs the general practice residency there, and they see most of the states of Utah as special needs adults. And he does a lot of sedation dentistry, and he's probably seen a lot of things that can help us if he has lots of expertise. And then Dr. Gerald Bozeman is a instructor at the dental school, and he teaches the special needs courses here. Is also the section head of oral diagnosis. So they're here to just help answer questions.
Well, we're grateful to have all of you. Thank you for the work that you do and for joining us today. We had a question about whether there are any keto-friendly oral rinses. Is the xylitol one keto-friendly?
That's a really good question. I don't know if it is. I don't know.
All right.
I'm stumped. I'll have to find out. And is there a place I can get back to?
We'll
these?
get back to you.
Okay.
I'll note who asked that and we'll get back to you.
Okay.
I would guess that there may be some keto-friendly rinses that would be appropriate for adults. For example, Listerine is a pretty high alcohol content, and that might be sugar-free, but we don't really recommend any of those type of products for kids. And so to anything that makes it palatable for kids is probably going to have sugar in it. So I would guess the answer is no, but I don't know specifically. I'd have to do some research.
And you know, the goal of these sponge soaked suction rinses is that they don't swallow it. So I can't imagine that it would make a big effect. I know that xylitol does affect blood sugar. So I'm assuming it would have some sort of effect, but that's consuming xylitol. So, you know, if you're just rinsing with it, I really doubt it. But chlorine dioxide doesn't have any sugar in it. So closest would be a good option.
Mhm. Yeah, and a question came up also about how often do you recommend using chlorhexidine? And you mentioned not every day. We've been using it every day, so it's a question I'm curious about too. And then you mentioned some of the alternatives.
Yeah, chlorhexidine does cause staining after a 3-week period is about how long that they know that it starts that staining process. Very difficult to remove that stain. It depends on the reason why you're using it. So that's why I mentioned, you know, you'd want to consult with your dentist and not use it for reasons other than what it was prescribed for.
Mhm.
But if you're using it for aspiration pneumonia risk, for instance, to reduce bacterial load, you know, you can use it once a week without having it cause that stain.
Mhm. Great. Do you guys have any recommendations for on fluoride versus non-fluoride toothpaste for children who are likely to swallow the toothpaste?
Yeah, this is a question that comes up a lot, especially at that 12-month visit. You know, should we be using a fluoride toothpaste? You know, Shannon did a good job explaining how dental cavities start. And you could have tremendous oral hygiene, but still have cavities, unfortunately. So the one thing that works that's been proven is fluoride. So I would recommend a fluoride toothpaste early. The secret is then just to use a minimal amount so that kids that do have aspiration risk or dysphagia aren't swallowing too much. And so it's not whether or not we use fluoride toothpaste, the answer is yes, we do. We just limit the amount. So for an infant toddler, we recommend like a grain of rice amount. You know, that's not going to be too much. That's going to do the effect on the teeth, but not create a lot that goes down the, you know, the pipe. So for youngsters, it's a grain of rice or what we call a schmear. And then as they get a little bit older, you can use a little bit bigger of a dollop. But again, it's unique to each individual. So if you have a child that literally cannot swallow, cannot manage their secretions, you're limited always to just enough to give you the benefit on the teeth of the fluoride, but not so much that you can't get it out or have them struggle with swallowing it.
Mhm. And if you have a suction machine, maybe that suction toothbrush, the toothbrush with the suction on it.
Yeah.
Also, you can, when they're very young, when teeth are still developing, you have systemic fluoride drops that you could put through their G-tube. You have to talk to your medical provider to find out if there's any interactions. So you might want to do it without other meds because fluoride is such a reactive molecule. It could react with other meds if you're putting it in the same G-tube at the same time, but we gave it by isolation, so like on its own, dropped in water through the G-tube, and that helps the developing teeth, the permanent teeth, while they're very young.
So I think you started to talk about this a little bit, and I saw a picture of it, but how do you clean the teeth of a child who does not really open their mouth? You have a tool, I know. I know
the
that
video going.
Well, one of your slides I saw had a picture of somebody getting a mouth cleaning with I don't know the actual name of the device. We have those too, but.
Yeah, there's like a bite block. It's a bite block or a tooth pillow, or that one is it's like a soft molded rubbery kind of, it's soft, but it's also firm. And you hold it in one hand while you brush one side of the mouth, and then you switch to the other side and brush the other side. It's it's really difficult to get someone who doesn't want to open their mouth to open it, but that's one tool. You can buy them from special care services online. You can Google it on Amazon and they have them. Just make sure they're soft. There's some that are hard, like a plastic hard, and that's going to be traumatic to someone who has a neurological disorder who can't really control how hard they're biting down. So yeah, I recommend a soft one.
Yeah, there are commercially available products, but here's a real easy way to do it too. And it's variable in terms of how big you make it. So you just get a box of tongue depressors, and you can get 2, 3, 4, 5, however thickness you want, and wrap some gauze around it, like a 4x4 or 2x2 gauze, and then wrap it with some tape. And so you can make it as thick as you want, depending on the child's age and their cooperation. And like Shannon said, you can use it on one side to prop this side of the mouth open just enough to brush over here, and then you switch sides, and that gives you access. And so sometimes it requires 2 people to help you. But yeah, just literally some tongue depressors, something wrapped around to make it soft, and then some tape on there to hold it in place. And that's very cheap, inexpensive, easy to use.
I love the hacks. Yeah, we need life is all about hacks. Well, I want to invite Dr. Proctor and Dr. Bozeman to share any other additional thoughts they might have from listening, or in your practice, what you found most useful for families.
Welcome. Great job, by the way, in presentation. We kind of see the graduates from Dr. Reinemer's program, and we take them on when they become older. And so sometimes treating patients with special needs or developmental disabilities, because they're big people now, is a little bit more difficult. It can take 2 people to brush teeth and kind of manipulate them a little bit to hold their heads and hold everything steady. But a lot of the principles they've discussed apply to big people. And we try to teach people how that live in group home situations or live at home with aging parents, how to hold their child still, or their son or daughter, I should call it, and still effectively brush their teeth, use mouth rinses, and take care of their oral hygiene. So we just kind of modify a lot of these skills that have been talked about in the seminar, and they work and they're good. So anyway, that's all I can add right now.
And I too would add my accolades to Dr. Reinemer's and Shannon's comments. Very insightful. And probably the one thing I would just say from my perspective as an educator trying to teach special needs to our up and coming future dental professionals is that through the educational process at the University of Utah, at least, we're trying to make our dental students and future dentists more aware that this is an area of need, and to help educate them and how to advise parents, help to get these children to the pediatric dentists or those who can provide the services they need. And so I've found that through this process that our students are very willing to learn about treating special needs individuals, and gives me a lot of hope for finding solutions to providing care for the future. So thank you to Shannon and Dr. Reinemer and everyone that tuned in to listen.
Yeah,
Great
no, thank you.
information.
I think we all probably recognize that there's a gap in care for a lot of our kids. And I think it's so wonderful to know that y'all are out there doing this work and building the next generation. Is there a place you can recommend that people can go to look for the closest dentist that might have experience with complex kids or special needs? Is there a website that lists that?
I'm not aware of a website. Anybody else?
You can get recommendations for like on like the Special Care Dentistry Association website. There's a find a provider function. They can help you find providers that treat adults with special needs that have been through like a fellowship or diplomat process with that organization. But the AAPD is a good reference. So if you have a child with primary teeth or mixed adult and primary teeth, that have pediatric concerns, then most pediatric dentists, if they are not comfortable, they might know someone who's comfortable.
Mhm.
Yeah, I would say in the pediatric world, it's the American Academy, which is aapd.org.
Mhm.
And then the American Board of Pediatric Dentistry as well, which is abpd.org. Both have find a dentist links within that will direct you in
Also,
your respective community.
Okay.
and also looking for teaching hospitals, like medical schools that have hospitals associated with them often have dental programs, and educational facilities that are going to have more specialists that kind of communicate with their dental programs. That's looking for that is helpful.
Mhm. Yeah, that's great advice. Well, I have plenty more questions. And so maybe what I'll do is, I think maybe what we can do is create a Q&A or something like that based on a lot of the stuff we went through. And if you guys would be willing to answer a few more questions, that might be helpful. And then we'll put that on the website so people have an easy access resource to get answers to a lot of these questions, because it's really spectacular. Thank you all for joining us. I really look forward to this being a resource that's available for families out there. When it's up, we will send it to you and you guys can use it however it can be useful to the community. And we're really grateful for you all being here today. Thank you everybody for joining us, all these families. I see some new names here coming in. Thank you for joining us. And we'll look forward to seeing you at our next webinar next month, which is on ketogenic diet. For those with DEEs. So stay tuned. Be sure to follow us on Facebook and Twitter or wherever social media you are so you can see what's coming. And we'll post this webinar once it is loaded into our resource center. So thank you so much, Shannon, Dr.
Thank you.
Reimer, Dr. Boseman, Dr. Proctor. Thank you for all you do and for being here today with us.
Thank you for the opportunity. Appreciate it.
Take care.
Thank you.